can kind of tape this down. You can put your tape on this. This is sterile. I'll show you a couple different ways. I always split that tape because it's too damn fat. Let's go like that. We'll see if that works. I haven't tried that really. Now you take your stuff. In this case, in our case, it'll actually be a thing like this. This is just glass in there. When you squeeze it, it busts it. It'll just be a little stick in our case, and we just go like this. We're kind of looking for sites. Oh, that looks okay. If you see a site you might like, you go, okay. I always do this. This is to test it because they break sometimes. Also to take some stretch out. When I put it on, let me show with, I don't even need one. Just go straight in there. No.
Blind.
I stretch it behind and then pull around. Don't put it on and go, because that pulls the skin. Get it? Especially with old folks and kids, you don't want to do that. That's locked on. Then I can look. I like that one right there.
Let's do that there.
Squish. Take the buffer lidocaine. I'll go. And I'll put it right next to that vein when I see it. About half just like a TB. And I'll pull that off and let them sit for a while because I'm going to get set up now. Because I'm a student, it's going to take me about an hour, so I'll get all set up. Don't rush, you know what I mean? I don't even rush now. If the person's not dying, I'm not rushing. Take your time. So that's how you do that. That's how you set up. Now we're back here. It's Jeffrey's arm again, right? I'm not going to stick Jeffrey's today. So now I'm like glomming all over here. I know where my spot is. I'm going to actually just make sure I clean it up good. Because a lot of times with the buffer, a little blood comes out too. So we'll do that. Get our stuff ready. Tegaderm. Yeah, I got a Tegaderm. You can open it. Go like that. Now I'm pretty much set. Now I'm going to put the tourniquet back on. I got my catheter thing. Figure out how it opens. Check the expiration. 2014, we're all right. It's always good because, you know, things get kind of messed around in the hospital in like med drawers and stuff, and sometimes you pull something out and it's like 2011 or something. And you go, that's not great. And before I poke them, I'll make sure I have this. Students always lock this up again. Drives me nuts. Don't lock it because what's going to happen is you'll attach it and then you have no way to unlock it because your hands are tied. So just make sure this is kind of loose. Otherwise, you don't want to do that. They're just made for that, but don't do that. If that ever happens in an emergency and you end up doing that, just spit it out. Don't put your gloves in your mouth trying to fish something out. That's a good way to get yourself sick. So anyway, there's that. I'm set. I see where it is. I'm ready. Go like that. Tourniquet's on. Now once you open this, this is sharp. So anything sharp should never leave your visual field. If it leaves your visual field, it's definitely going to get stuck in something. You don't know what. Also, technically, if you turn your back on a sterile object, not sterile, right? So I've done this again. Oh, look, I put my finger on there again. Rats. Clean for 20 minutes, right?
20 seconds.
Seconds. Oh.
20 minutes.
Okay. I know my bevel is up because this thing is up. This is the kind that has the little tab. You have to look wherever you're working. You can pretty much figure out how these things go. They're really pretty basic. Make sure it's going to slide. Yeah. Okay. You want everything to be kind of loose. Okay. So there's our vein. We're right there. Little downward traction. I'm hoping I'm where I put the buffer lidocaine. Is this thing open? Can you open those, Jeffrey? These two valves. On real people, you don't have to open those valves. Hopefully. Then we're going to put, and when I put down on the surface, even the studies say, if you push down a little bit, that actually helps numb the side a little bit too. It makes a positive point of contact, a little pressure. You have a little flex, and you want to just kind of move smoothly. And I can tell already I'm not there. You can come back. If you come all the way out, you got to start over. You got to get a new needle. If you come out and you're just out to here, you're going to remaneuver. You can just change your direction. And there. So I'm in. You can see that build up. And I gave it a pretty good shove because it's surgical tubing, so I have no idea. But I'm always talking about SOH. You just move in a little bit to make sure you're in the lumen. In this case, I know. The times you don't want to, after you get flashed, or you don't want to move it forward is with pediatric patients and with really anybody with fragile veins. Because if you push forward at all, you won't be able to feel it like you can on, like Jeffrey, I could feel I'm in the vein, I'm out the other side. But an old person, you'll pass right through their vein, you won't even know it. You won't feel anything. You'll see it, but you won't feel it. So now I got to get that catheter off the needle. So you can do it like that, one finger, or you can do it like this. Brace your hand and just slide it up. All the way up to the hub. And then you've got to get that needle out. On this gel coat kind, you do that by pulling back. On the kind, as Margie pushed, you just push the button and it pops out. Again, people, if they're really fragile, will sometimes extract that needle all the way out to this hub part before they push the button because they don't want to have that needle shake anything. Now I'm good. Nothing's going to leak out of here or anything. It's pretty stable. And you can take your tape. You can stabilize it a little bit if you're using one of these. If you're using the other kind with the spring, you got to kind of take this off first. But I like to stabilize it a little bit. That's a chevron. And you can also pop your tourniquet. Once you're in and you've slid that hub up, you don't need the tourniquet anymore. You can just pop it off. Push my finger there a little bit. And the winds at Wilcox have wings like this, so you can actually just kind of jar this loose a little bit. You see how it wants to come out? Push a lot of pressure, it still doesn't work. Yeah, that's why you need to be kind of ready. Some people, once you push that in, it'll stay. Is it still leaking? This is because it's Kool-Aid and surgical tubing. Most people don't bleed that quick. Then you screw this part on. Yeah. Now it's screwed on. Now you clean up your mess. Sometimes you get some blood under there. It's like, Sometimes you can't. Sometimes you got to change your tape. All kinds of junk happens. Thing is just methodical. And then this piece goes across the top of that. Now that's still sterile, and we used this technique so we didn't contaminate anything. And now this part can just sit right over there. Now I don't put this over the screw-on part because the screw-on part can come loose, and if you've got this tegaderm on it, it's going to be really hard to tighten it. Or if you have to change it out for some reason. So you've protected your site. Flush them and you're good. Now if you've got help and it's stable and everything, you can flush it as soon as you've got that thing out before you tape it. You know, I'll hold it while you flush it. You can definitely do that. It's kind of situational. And then you want to do positive pressure where you do this. You get it set up like that, pushing and you at the same time. Which is a mess and I hate it, but there you go. And then this one you can tape with another piece up here. And hopefully, or you can tape down, depending anywhere that's going to be handy. You just want to be able to see the site. I tend to tape on the tegaderm so I minimize the amount of tape I have to peel off a person's skin. And you can use that. You can go down here. A lot of people put it down lower. It kind of depends on the patient and where you put the IV in and where you're going. That's actually a better place. And then you fill out your little label, wherever that went. your initials and the date and what size, although they can tell it's a 20. Then you just stick it on the side. Boing. They don't like us to write on the patient, I guess. I don't know. Never bothered me, but that's okay. The other way you can do that, if you want to not, you can put this catheter in, you can slap the tegaderm on, then you can do the chevron over the top of the tegaderm. That's even more sterile. And it's also nice because you don't have to monkey around with tape, you just tegaderm the heck of it, it's straight down, and it's sealed on. I'm not sure which way they're really going to be doing it on Wilcox, we'll have to kind of eyeball where they're at with it. I know in the ER we still do it this way.
And then take the answer. To take it on top of the tape.
Yeah, the big issue is just not to put the tape on the
Table.
Let's say
Table or side.
Yeah, and that's a pretty good solution Michael had. Or you just peel it off altogether, and so that worked pretty good. And then you know how to remove IVs already, right? You guys have come there, so that has not changed. Okay, so